So extreme access and CLI go along together. CLI is common, and did you know there are more people alive today than they have ever lived on Earth, 7.6 billion. CLI is common, it's here to stay. Now, this is a case where the question mark is because I'm not sure if I was proud to do this. We discussed in the previous previous session that when do we decide we don't do this case or we do this case, and what do we do with it? So hindsight is 20/20, but I think this is a very routine case for many of the expert operators here. But for me, there were many times when I thought, should I give up? Should I send for surgery? And what should I do? So I would appreciate your attention here. So once upon a time, last year, 58-year-old man, hypertension, history of smoking, 22 years ago had aorta bifam bypass. Bilateral claudication was referred by the surgeon. Patient had more symptoms on the left, but he had already done an MRI, and there was bilateral anastomotic stenosis, and the ABI was a little worse on the left side, and there was multi-level disease. Now, when I saw him in the clinic, he was Rutherford 3 claudication, and I had planned for revascularization. However, just 3 days later, the patient presents with CLI. So he presents with the other leg, which the ABI was actually slightly better at 0.4. He presents with extreme pain and bluish toe, first, second, and third toe. So there will be multiple points where we'll need to stop and think. So you see the graph. The graph looks beautiful from 22 years ago, but this is where all the problem lies. So there is this anastomotic disease here, but there are a couple of rocks here throughout the osteal SFA. So anastomosis, stenosis, osteal SFA calcified, severe stenosis, and then there are a few rocks downstairs over here. And then let's keep looking. Where else can you have the disease with typical CLI? All right, so then you have a popliteal occlusion, and so we are hoping for some good news. Fortunately, there is good two-vessel runoff. All right, so this is what's causing the CLI in the forefoot. So what are our options? So now do we stop? Fem-tip bypass, pedal access. How about left brachial access? Patient is 6'3". I don't have the radial access kit that's available now from Terumo. Or do we do multi-access? So we'll see. From brachial, I went from brachial, so this is the angioscore balloon, because I wanted to plaque modify the anastomosis site, but didn't want to atherectomy it because that would shred the anastomosis site. So that's at the anastomosis site, we did an angioscore balloon, and then we did atherectomy on the CSI atherectomy on the SFA. However, obviously, as you can imagine, the biggest limitation is the length of my catheter from there. So that's the sheath, and then nothing would go below this level. So I proceeded with pre-dilatation and then drug-coated balloon for the whole length, actually up to here, up to the CFA with a 6.0 DCB. So what do we do now? Now we need a straight line flow. The patient is the toe is pretty sick for any want of blood. So anyway, so this went well. So there's a brisk flow downstairs, but what do we do next? So I went antegrade femoral access because of the catheter length, and then basically try to define the popliteal occlusion better. And I was surprised how ambiguous the CTO was proximally. I spent quite a bit of time, really. This took much long. This was the longest time that it took for the procedure, and could not succeed from antegrade, from up above. So went pedal access, and basically at that time we were able to cross the popliteal occlusion with a 035 system actually. And then we externalized it into the antegrade system, and then did a atherectomy, and then I hope that I didn't have to stent it. Unfortunately, that didn't work too well, so I ended up putting in a supera stent. So why am I showing this case? I mean, this is a regular case that most people here do. So this is what happened next. So anyway, so this is the runoff. I still have the sheath here, and so once I took the sheath out, there was flow in the AT. So what happened? So there are 3 accesses. We get manual hemostasis on them, and then around an hour after that, after the hemostasis, the patient has acute limb ischemia on the right leg. Now, obviously, this is a case that we are showing because of the access points. So what do we do? What are our options here? So first of all, I think what happened was that the whole thing thrombosed. So now I converted a CLI patient to a acute limb ischemia after all this work that I had done. So at this time, we have a hemostasis here, so I didn't want to go antegrade at this time. I just went brachial, took a picture, see what happened. So there's a whole layered thrombus all the way from here. Obviously, this was not like this when we finished it. And then basically subsequent, all badness down there, very slow flow, thrombus there, barely flowing here. AT is thrombotic, so slow 2-vessel runoff. And then basically, again, more bad down there. So what do I do here? What do you do? So I thought I'll just take my chances. I start from the basics. So first of all, I went there, and we don't have, so maximum the catheter length will come up to here. So there are 2 options. One is try to do whatever you can do from brachial. I didn't want to go antegrade again because that's the spot where the thrombosis happened. And then the other option is again try the pedal axis again on the DP axis. And the third thing is, of course, is pharmacotherapy. So number 1 thing I did was I gave some integralin, like coronary double bolus integralin topically from there, and then ballooned it. Actually, then did a DCB and then hoped for the best. So there is a bit of flow here, not perfect, and then there is all this layered thrombus where I cannot get any device down to get it. So then I went ahead and gave more Angiomax. So this time I did with Angiomax, unlike the last time I did with heparin. I gave more integralin topically. And then with all the pharmacotherapy, I really wanted to give the pharmacotherapy the best chance that it can. So I've started getting some flow, but there is, my target is obviously the AT. The forefoot was the initial problem, and the ischemic toes. So I'm still trying to get this, but I don't have anything to get into. So what do I do? So what I did is I J'd 035 angle glide wire and then pushed it through this AT all the way down, and I saw it follow up. I knew there was no disease, it's all thrombus. So I J'd it down to hope the best for to get just some flow in there. So with all that, this is all that I got. And then of course this is the outflow. So basically, this is the end result. What I have is I do have flow there, obviously not antegrade. I do have retrograde flow from the pedal from the PT. So at that time I thought that let's give it a chance. Let's see how he does. So kept him on 24 hours heparin. Next day, I got lucky. There was 3-vessel antegrade runoff, and patient finally did well. At 8 months, has follow-up ABI1 and 3-vessel antegrade flow, no restenosis. Patient saved all his toes and everything else. Thank you for your attention.